Jeff Hersh is our global CMO of GE Healthcare, and he's been in this position for the past 10 years now. He's also the CMO of HHS, and he's been in that position for 5 years. He's a board-certified physician in internal medicine, pediatrics, emergency medicine, and disaster medicine. He's also in the board of directors of the American Diabetes Association in New York City, in the Operation Dragonfire for the Center for Disease Control, the Emergency Preparedness Institute, and on the board of trustees for the Alexei Scholarship Foundation. He has held faculty appointments at Yale, Dartmouth, Cornell, Tufts, University of Massachusetts, and Harvard. He holds a medical degree from the University of Miami, PhD in theoretical physics from Yale University, and MS in electrical engineering from the George Washington University. I would like to now hand over the stage to Dr. Hersh.
Pretty excited to be able to talk to you a little bit about ultrasound, and particularly about a handheld ultrasound. I think in general, everybody who's listening in understands how useful a tool ultrasound is, both in diagnosing patients as well as in managing patients. And with the present pandemic, this is even more true. Bedside evaluation has become much more important, and bedside evaluation of your patients to look for changes is even more important. However, there are a couple of limitations with ultrasound. Sometimes you have to look around for it. You might, at least I've had this experience, you might have to compete with some of your colleagues for access to the device at any given time. And you have to bring it to the bedside, you have to clean it, etc. So what would be even better? And I think the answer is, what would be even better would be to have an ultrasound literally in the pocket of your lab coat. And you could just pull the device out of the pocket of your lab coat. It'll be right there in your hand. You have your probe. I always keep my ultrasound gel in the other pocket, and I'm pretty much ready to go and ready to evaluate my patients. So this is what we're here to talk about today. This is the Vscan Extend. I'm extremely excited to be able to launch this product to help you care for your patients, especially during this pandemic. And right now we have a video which will show you a little bit, and then I'll be back and I'm going to talk at a pretty high level about some of the functionality and some of the things you can do with Vscan Extend. So let's go to the video.
Introducing Vscan Extend. Vscan Extend is designed for speed in clinical encounters. The system starts in less than 10 seconds from standby. The dual probe linear and sector transducers are always connected and always with you. There's no need to find the system and untangle the probes. Vscan Extend offers high-quality imaging out of your pocket to cover a broad range of clinical decisions on the spot. Using Vscan Extend feels like using your smartphone. Vscan Extend is GE Healthcare's first ultrasound system to leverage the GE marketplace, offering applications with a wide range of capabilities. Seamless image storage and data transfer connect Vscan Extend to your workflow. Vscan Extend. Speed in the critical moment. Simple, fast, precise. GE.
Okay, so I'm going to give a high-level overview on some of the features and some of the functionality of the Vscan Extend. And then we're extremely lucky to have some truly world experts in the field who are going to do a deeper dive about a couple of topics, including the pulmonary aspects of it, as well as the cardiac aspects of it. So my goal here is just to do a bit of a high level. Vscan Extend, why is this so useful? Well, it's very simple, so That's going to enable you to be able to use it. Literally, as I just showed you, you can pull it out of your pocket. It's very quick. And yet, despite how fast it is and how simple it is to use, the image quality is incredible, and that is going to enable you to give excellent care to your patients and make good patient management decisions. So what do we mean by simple? It's very easy to use. It's portable. We're going to talk about a couple of the apps that are built into it. In that sense, think about it more or less like your smartphone. You pull it out of your pocket. It's got apps on it, kind of easy to use, and it's very easy to clean. As you can see in the bottom picture here, you can also cover it, especially if you're going to be using it with patients who may be contagious. What do we mean by fast? Well, it's extremely efficient. It has a dual probe built, literally built into the device. The boot up is incredibly fast. You can do it even with your gloves on. And then you can connect via Bluetooth, so you can upload images, and so you can also do your documentation. What do we mean by precise? Without really high quality images, you're not going to be confident in the diagnosis that you make, as well as the management decisions that you make. So the screen size is a bit larger, and more importantly, the image quality is exceptional. It'll help you. Obviously, you need to have the expertise. You're going to be the patient manager. You're going to make the clinical care decisions as is appropriate, but this tool will help you do that. And as I already noted, the documentation is enhanced by some of the functionality built into the tool. So why is this particularly useful in the present pandemic? Well, there are some things which are kind of bread and butter that we need to do for patients that we suspect may have the COVID-19 virus, or that have it and we know are infected with SARS-CoV-2 and that we're trying to manage. So I'm going to just at a very high level go over four areas. The first one is lung, the second one being cardiac, the third one being shock, and then the fourth one being IV access in general. So when we say lung, what do I mean by being able to use this in lung? And the answer is just like we always do in lung. That is, we can look at the patient's chest, be able to see different aspects of their lung, particularly including the lung parenchyma and the pleura, to help figure out what's going on with our patient. Now, everybody has a different methodology to how they do that. All I can say, and what I teach my residents, you figure out what works for you, but you need to do it the same way every single time. If you don't do it in a systematic way, you'll forget something, you'll miss something. And furthermore, as you manage your patients and look for changes over time, by doing it in a reproducible, systematic way, you'll be able to identify changes. When I'm evaluating a patient initially, I usually use the Blue protocol, which was pioneered by Dr. Daniel Lichtenstein, but you can use any of the protocols that you feel work best for you and that you're most comfortable for. So this is just one slide, a bit of an idea of a Blue protocol. Well, what am I going to be looking for? Well, the answer is I'm going to be looking first or second, depending on which order I do, but I'm going to be looking at the lung parenchyma. As you can see here, you might be able to see consolidations. You will be able to see B lines if they exist. And just to remind some people, I'm sure you already know this, but scattered B lines can be one of the pathogenic findings in a patient who has COVID-19. But of course, it can progress to a confluence of B lines and even focal consolidations. And then you'll also want to be looking at the patient's pleura. Well, you'll be looking at the patient's pleura for a couple of reasons. Sometimes, not super common, but sometimes patients with COVID will develop a pleural effusion. So you want to be able to look for a pleural effusion. And then, of course, the patients may develop a spontaneous pneumothorax, or if they're intubated and they have an acute clinical change, that can always be because they then develop the pneumothorax, and you'll want to be looking for a pneumothorax. And I have here, just for completeness, what most people call, or many people call, the Shore sign of what normal pleura looks like. I have one of our colleagues here who's actually much more clever than I am. Will be talking to you in much more depth about some of the lung findings. So what about the cardiac findings? Well, as I told you, and will continue to mention a couple of times throughout this presentation, doing things in a systematic way is incredibly important. And so if you look here, one of the nice things about the Vscan Extend is it has applications built right into it. You can see here an application which will walk you through the lung exam. And what that will do is remind you these are the different areas of the lung you'll be looking at, and it already helps you document those. There's also an application which will help you walk through the cardiac exam, and there's an application which I believe one of my colleagues will talk a little bit more about, which will help you calculate the ejection fraction. So once again, systematically is incredibly important, both for continuity of care as well as care from one caregiver to another, and to look for changes over time. So what will you be using this for? Well, the first thing you'll be doing is looking overall for the cardiac function. And as you can see here, you might have a patient who clearly has reduced ejection fraction. And as I noted, and I believe people will be talking to later on, there is a built-in app called LVivo EF, which will help you calculate the ejection fraction. So you can look at that as it changes over time. And then of course, you're gonna wanna be able to also look at the pericardium. And here's one example of why you might want to do that, of course, looking for a potential pericardial effusion. There are, of course, many other things. You may be looking for baseline cardiac function, for valvular disease, but my colleagues will talk much more about the cardiac. And what about shock in general? Well, shock from a SARS-CoV-2 infection can be due to many reasons. It could be due to cardiac tamponade in a patient who happens to have pericardial effusion. The pericardial effusion, as we noted, not an incredibly common, but definitely a possible complication of a COVID-19 infection. They can develop a pneumothorax. As all of you know, unfortunately, this infection puts patients into a hypercoagulable state. So they are at an increased risk of developing deep venous thrombosis, which of course puts them at risk for a pulmonary emboli, which can lead to shock. The most common one that you'll see in any patient with an infection, including patients with a COVID-19 infection, is distributive shock, particularly due to sepsis. And although bleeding per se is not an issue, just for completeness, I did put one slide in here about blood loss. And then monitoring your patient over time. Are they responding to your treatments? Are you treating them appropriately? Is their clinical condition getting worse? Is it getting better? So monitoring for treatment response, as well as monitoring for changes over time is possible. So shock causes. I already showed you a slide here. I happen to have two of pericardial tamponade, pericardial effusion leading. Well, neither of these patients have tamponade, but pericardial effusion. You can, of course, have a pneumothorax, and this is an example of a patient with a pneumothorax. And you can see here the lung point where it goes from a lung that does have a pneumothorax to a lung that doesn't. And being able to do this will help you estimate the size of the pneumothorax. As we noted, these patients are at risk for being in a hypercoagulable state. And so you might want to look for deep venous thrombosis. Of course, you might want to look at multiple different veins, but one of the big ones would, of course, be in the lower extremities, especially in a patient who may be bedbound and may not be able to be ambulating. Distributive shock in sepsis is, of course, the thing we're going to see most commonly. Everybody here knows that you'll be initially in a hyper state where you have actually increased cardiac output very early on in sepsis, but later in sepsis, you'll unfortunately have some compromise of your cardiac output, and you'll be making decisions about how to manage these patients. And then although bleeding is not one of the things that you would expect, just for completeness, because it is a common cause of shock, and of course, the most common cause of shock in patients who have trauma, you would be able to potentially have blood loss, whether that's in the patient's abdomen or whether it's in the patient's thorax. Extremely important, and going back to our theme of managing our patients and evaluating our patients in a systematic way. When we have a patient in shock, there's always three things that I try and think about. The first one is the pump primed? Do I have enough fluid? The second is the pump working well enough? What is my cardiac output? What is my ejection fraction? And then the third one is, did I accidentally overdo my fluid management? And have I now created an issue? And so when you do this, you're going to look at your patient. Is the pump primed? Now, there are many ways you might want to do this. And there are many ways that people do this very successfully. Some people give a fluid bolus and then look for changes. There's even some literature. You can give a fluid bolus, and you can use Vscan Extend to look at a different flow, for example, in somebody's carotids. But you can also look at the inferior vena cava and look for collapsibility of the inferior vena cava. Again, you need to do what is your protocol and what you're most comfortable with, but assessing whether you have enough preload is an incredibly important aspect of managing a patient with shock. Secondly, and now I know you've seen this slide, or at least this motion picture multiple times, but what is my patient's cardiac output? Is it time for me to go to pressors? What should I be doing? How is my patient doing? And if they're not doing well, why are they not doing well? And then finally, did we overdo it? Did we give too much fluid? Now, because you can get scattered B lines as one aspect of the underlying COVID-19 infection, you will always have to interpret the B lines as whether they are infection, or put this in the clinical scenario, did we potentially give too much fluid? And have I developed B lines because of over resuscitation, at least over fluid resuscitation of my patient? Now, for all of this, I've assumed you're able to treat your patient. And step one in being able to treat my patient is being able to gain IV access. Because without IV access, I don't have the ability to give a lot of the life-saving medications, as well as to potentially make it easier to draw bloods and do my evaluation of my patient. Here you can see an example of starting a peripheral line using ultrasound. I'm sure all of you are pretty familiar in doing this, but you of course can do this to start a central line as well. As you heard during my introduction, in addition to my role for GE, I'm the Chief Medical Officer of one of the United States disaster response teams. Coincidentally, I was literally activated last night, and I will be going out the door in just a couple of hours to respond to one aspect of the COVID epidemic, which is, or pandemic, which is occurring here in the United States. So I literally will be going out the door in just a few hours to help some of my colleagues respond to this. But just as a quick anecdote, I was out in the field with a couple of residents, and I asked them to, quote, could you just pop in a central line, unquote. And this is when I deployed to Haiti after the earthquake. And I asked one of my residents to do this, and my resident said, where's the ultrasound? And at that time, I did not have a pocket ultrasound that I always brought with me. I honestly do now, but I didn't have it at that time. And I said, well, you know, the anatomy, just pop it in. And my resident said to me, I've never done it without an ultrasound. So I'm sure people are aware of just how useful this is and what an incredible tool it has become. So in summary, why a pocket ultrasound, and in particular, why the Vscan Extend? And the answer is we've worked really hard to design it so that it's simple, so that it's fast, and that so it's precise. And in all these ways, so that it can help you in diagnosis and management of your patients. And during this pandemic, particularly, what will you be looking for? Well, of course, you'll be doing the usual things you do with ultrasound, but I believe during the pandemic, there'll be an extra emphasis on lung, cardiac shock, and IV access aspects for it. And so with that said, I will hand this over to some of my colleagues who will be doing a much deeper dive into some of the aspects of ultrasound and Vscan Extend for the pandemic.
Thank you, Dr. Hersh, for the launch of the Vscan Extend and how it is an essential tool for critical moments.